Well, Harry, this is a real big honor to be asked to interview you because you were my fellowship director and mentor, and you've really been a mentor throughout my whole career.
Even though I tried to take you in the wrong direction.
Well, that's okay.
In the laboratory. But you learned better.
Well, we'll get into that.
Yeah.
But I really find it a real honor to have the chance to sit across from you and to ask you probably some questions I've been thinking about my whole life about how you would have responded because you interviewed me when I was a resident interested in a glaucoma fellowship, and now I get to interview you and really find out.
Do I get a fellowship if the interview goes well?
Yes, you can have a fellowship
Wonderful.
with me.
Good.
I'm sure I'd be...
Fantastic. I'd finally get some real epidemiological credentials.
That's right. And we'd get you out to California.
There you go.
So one of the first questions that we've been asked to ask is really, why did you go into glaucoma? It's something that you're asked when you're a resident, possibly even when you're a medical student, but why did you go into glaucoma?
I made a list. I think I was in the second year. I made a list of the various subspecialties that existed at the time. Not all of them that exist now existed then, but most of them did. And it seemed to me that glaucoma combined a whole bunch of things none of the other specialties did at the time. It combined long-term care of patients who you got to know. There was pharmacology, there was surgery. Even then there were lasers involved. There were a lot of basic questions that needed to be answered. I thought it combined most of the things that you could do as a surgeon and also as a scientist, and the problem seemed to be challenging. And I wasn't particularly put off by what I think often puts people off, and that is that with glaucoma care per se, patients don't get better. With cataract surgery, they get better, occasionally with retinal surgery, and now especially with some retinal treatments, people do. And so I thought people at that time saw it as being rather lugubrious. You know, it was a downer of a specialty. You know, the patient never sees any better. I thought that was a challenge we should take on and see what we could do about it.
Yeah, so would you choose glaucoma now? Because the field is different.
I think it's even a lot easier right now for young people to choose the field because there are a lot of challenges. I mean, first, if you love cataract surgery, you're doing the most complex cataract surgeries that get done. I think doing cataract surgery in glaucoma patients, which I'm not presently still doing because I have junior colleagues who are better at it. But I think that those in glaucoma do the tougher cataract situations. We just heard one in a symposium this afternoon. The lasers are there. We have much more complex pharmacology. We have laser imaging devices, which have come about since we had only photography at the start. So yeah, I think it's a much more attractive field, but ophthalmology is attractive.
Mm-hmm. And who are your role models and your mentors, and why?
Yeah, well, I know you were going to ask the question, and I thought back. I was extraordinarily lucky as, well, first my mom, because she was not a scientist, but she was someone who always thought that you should believe in yourself and your ability to do a lot more than you ever really thought that you could. When I went to college, I was looking for a job, and I stumbled into the laboratory of George Wald, who a couple of years after that got a Nobel Prize. So I was able to interact with somebody who was doing science at that level, had been doing science at that level, and saw how somebody's mind worked, who did this sort of thing, because you sort of need to learn it. A couple of years after that, I worked with Jay Enoch, who may be not so well known to the ophthalmology glaucoma community, but who is a spectacular PhD researcher and was the dean of the Berkeley School of Optometry. I went to Hopkins, and John Dowling took me into his laboratory. John became head of neuroscience at Harvard, and Ed Malmeny during that time was head of Wilmer and was terribly excited about glaucoma and the questions of glaucoma. Irv Pollack at that time was our glaucoma person at Wilmer and was just a super mentor to me, both personally and professionally. And then my fellowship was with Doug Anderson at Bascom Palmer, and I had the joy of learning clarity of thought and objectivity in science from Doug, and also learned that putting the new scientific methods that are being done in other fields, in scientific fields, to work on the questions that we want to ask is productive. And that's still what we're doing now with the more highly complex science that we're doing. So I think some people say, well, I had this wonderful mentor in the career, I had this great opportunity to work with all of those people and others. Anita Hendrickson, who started us all on the idea that certain ganglion cells might be selectively damaged, and was studying axonal transport at the time, and others. So I had a lot of fine people to work with and to learn from.
So, and have they kind of influenced how you mentor?
Yeah, I suppose that there are pieces of all of that in what you do. I don't know that mentoring involves very much more than being yourself, does it? I mean, that's what the word probably means. But I think we maybe think of it as being a very active process. I'm not so sure that we can actually understand what we're doing when we're interacting with someone. We simply do our very best to put opportunities in front of people. As time has gone on, I've had more and more chance to provide people opportunities because we get more resources. I now have 7 colleagues in our group, and as you watch the stair steps of people who've come along and joined our group, none of them looks very similar to any of the others. So I'm not so sure what real how I can possibly say I actually did something to mentor those people. I think it's just lucky that they happened to come and join us, or that you and others came and were our fellows.
So then the other question is, what do you think are the most significant advances in glaucoma during your career? That's a big one.
Well, for the people who are potentially listening to this now, they may not realize that when I started in this field, surgery was full thickness filtering surgery. It was a guaranteed flat chamber every time you did it, practically. We had no laser therapy, either iridotomy or angle treatment, and the drugs we had were pilocarpine, epinephrine, and Diamox, all 3 of which are really difficult on patients. So to think that we now have once a day fairly well tolerated drugs of at least one general class and a couple of others, including the beta blockers, when Timolol came along, it was a revelation that we actually would have something people were likely to use. We now know that adherence is not as good as we'd like, and we can act on that and actually intervene on it now, fortunately. But adherence with glaucoma therapy was probably closer to 0 than 80% in those days. So the fact that we had tolerable drugs, the fact that lasers came along to provide a middle ground was important in therapeutics, and laser iridotomy, which Irv Pollock and Arnold Patz and Al Robin made something that was practical for all of us. Imagine that we did bilateral surgical iridectomies 1 week apart with a 2-week hospitalization when I was a resident. Now that's scary. I mean, people laugh out loud now to hear that, but that was exactly what the therapy was. And now people drive themselves home sometimes after a bilateral laser iridotomy as an outpatient with no anesthesia. So those are a lot of positive things in the therapeutics. Automated perimetry came along. Anders Hale deserves tremendous credit as an individual for putting us all into an era of scientific measurement of progression. The laser imaging devices are probably going to be something that will ultimately be very good. I don't think they've really met the promise that we all think that they probably should have. We have a problem now with technology in that it moves so quickly with a disease that has a long time frame. We don't get a chance to learn what progression is on an instrument before a new technology supplants it. Here we're watching SDOCT come about right now, and the older SCTs never really had full software to tell you what happens in 5 years. So those kinds of things diagnostically are important. I think what we've seen even more so is when the glaucoma group used to get together, we would sit around and talk as a group of glaucoma specialists, and then a few people knew something about science. The Brubakers, the Steve Potos, Doug Anderson, I'll leave people out, but I'll give you those as examples of people who actually knew what was going on in epidemiologic areas. Al Sommer. They knew what was being done in outside glaucoma work and brought those ideas to the field. So the idea that we would be doing detailed work on optic nerve biomechanics, the way Claude Burgoyne and Crawford Downs and people working with me are doing now, by bringing in mechanical engineers into the field, that's a huge positive forward step for all of us in adding to our abilities to do it. Because after all, as clinician scientists, we're we're very busy. 2 or 3 days a week, we're taking care of patients and seeing people. We're not like a PhD who can expect that 5.5 days a week we're going to be in the lab grinding out mice. I think those are all. There's just some things that are worth mentioning. Yeah.
So then, when you look at yourself personally, one of the questions is, what do you think your contributions have been up to this point?
I think we began some time ago saying that we wanted to quantify what was going on with the patient in terms of the clinical and pathological correlation between glaucoma as a